Good day, I'm Louise Penera, and I'll be continuing our discussion on pain and inflammation management agents, focusing on opioid and non-opioid analgesics. We're going to start by defining terminologies. First is pain. This is the unpleasant sensory and emotional experience related to tissue injury. This subjective in nature is considered as the fifth vital sign. Another is the pain threshold. This reflects the level of stimulus needed to create a painful sensation in an individual. It varies across persons because of our genetic makeup. In our DNA, we have our mu opioid receptor gene that controls the number of mu receptors present. Remember, the larger the number of mu receptors there is, the pain threshold is high and pain sensitivity is reduced. Another term is pain tolerance. This is the amount of pain one can endure without having it interfere with normal functioning. Factors such as age, gender, culture, ethnicity, previous pain experiences, anxiety level, and other specific instances such as your traumatic event influence pain tolerance. Lastly, analgesics. This is a group of drugs prescribed for the relief of pain, and the choice of administration depends on the severity of pain. First, we have our non-opioid, also known as non-narcotic analgesics for mild to moderate pain treatment. For treatment of moderate to severe pain, we have opioid, also known as narcotic analgesic. So now we are going to classify pain. So the most common way to classify pain is to look at the duration. So acute pain, duration of 3 months, and chronic pain, duration of more than 3 months. Another way is by looking at the region. We have here our nociceptor pain. This is the pain originating from tissue injury. It includes somatic pain, or the pain from structural tissue such as your bone and muscle. And the other one is visceral pain, or simply organ pain. Another pain classified based on the origin is neuropathic pain. This is the unusual sensory disturbance, which often involves neural supersensitivity. Again, neural supersensitivity. Patient experiencing neuropathic pain complains burning, tingling, or electric shock sensations in the affected area and is often triggered by a light touch. Example of neuropathic pain is the neuropathy or diabetic neuropathy associated with diabetic mellitus, and then the pain associated with spinal cord injury. Now let's go to the physiology of pain. How do we perceive pain? So first is the pain stimulus. So pain stimulus such as your chemical, thermal, and mechanical noxious stimulus because they stimulate nociceptors or pain receptors. Now these pain receptors, when activated, they release chemical mediators such as your prostaglandins, substance P, glutamate, bradykinin, and cause formation of action potential along nerve fibers. Now this action potential, they travel different nerve fibers. These fibers are A delta fiber, which is wrapped in myelin sheath, and this property enables them to transmit impulses rapidly. On the other hand, we have your C fiber, small and unmyelinated nerve fiber, and transmits impulses slowly. So from afferent nerve fibers, they travel in the spinal cord and then to the brain, particularly in the thalamus, which relays the nerve impulses to the cerebral cortex. So now, once this nerve impulses reaches the cerebral cortex, this is when the person perceives pain and is consciously knows the feeling of pain. So how does the body suppress pain conduction? So when the body is exposed to stress or pain stimulus, it naturally produces endorphins that suppress pain conduction. Similarly, that's how analgesia work. They modulate and suppress pain. So first is our opioids. They activate same receptors as endorphins to reduce pain. And our non-steroidal anti-inflammatory drugs, they control pain at the periphery level by blocking cyclooxygenase. This is a pain sensitizing chemical, and the production of chemical mediators, prostaglandin. Then we have our cortisone. They decrease pain by blocking the action of phospholipase, reducing the production of chemical mediators, prostaglandins, and leukotrienes. Lastly, anticonvulsants used in the treatment of neuropathic pain. They inhibit transmission of pain impulse by stabilizing neuronal membrane and inactivating peripheral sodium channels. Now let's proceed with analgesics. So analgesics, so aside from pain relief, of course, its primary effect, they have antipyretic effects, so they lower elevated body temperature. Some analgesics also, like aspirin, has anti-inflammatory and antiplatelet effects. So now let's proceed with non-opioid analgesics. So this is less potent than opioid analgesics, and it's used in the treatment of mild to moderate pain. Non-opioid analgesics is very effective on the dull and throbbing pain of headaches, dysmenorrhea, inflammation, minor abrasions, muscular aches and pain, and mild to moderate arthritis. So one Class of non-opioid analgesic are NSAIDs, or non-steroidal anti-inflammatory drugs, and all NSAIDs have analgesic, antipyretics, and anti-inflammatory effects. An example of your NSAID is aspirin. This is salicylate NSAID, and it is not given to children and adolescents younger than 20 years old for treatment of fever and viral illnesses due to the dangers of Reye syndrome. So what is Reye syndrome? This is a rare but serious condition associated with viral infection treated with salicylates that cause swelling of the brain and liver. So instead of aspirin, acetaminophen is given for the treatment. Another property of aspirin is it decreases platelet aggregation or clotting. So healthcare providers provide one 81 mg, 162 mg, or a 30-25 mg aspirin daily, or one 30-25 mg tab every other day. This is a preventive measure against transient ischemic attacks or mini strokes, heart attacks, or any thromboembolic episodes. So how does aspirin and other NSAIDs work? So they inhibit or block both the cyclooxygenase 1 and cyclooxygenase 2 enzymes. So once the cyclooxygenase 1 is inhibited, there is a decreased protection of stomach lining, so you're going to expect gastric irritation and bleeding. On the contrary, once the cyclooxygenase 2 is inhibited, there is decreased inflammation and pain. Because of that, some pharmaceutical companies develop anti-inflammatory and analgesic drugs that inhibit only the cyclooxygenase 2. So these are called cyclooxygenase 2 inhibitors. This is developed to eliminate the GI side effects associated with aspirin and other NSAIDs because of the inhibition of cyclooxygenase 1. Side effects and adverse reactions. So aspirin causes GI distress, such as anorexia, nausea, and vomiting, and diarrhea. So to reduce this effect, aspirin is taken with food at or right after a meal, or with a full glass of fluid. Another effect is excessive bleeding. When used for dysmenorrhea, this is stayed for the first 2 days of menstruation. So here is salicylate toxicity, another adverse reaction to aspirin. So expect tinnitus, vertigo, hyperventilation, potential metabolic acidosis, and anaphylaxis. So hypersensitivity. Symptoms include dyspnea, bronchospasm, or tachycardia. Now let's proceed with acetaminophen, a non-opioid analgesic. So this is the analgesic effect of acetaminophen is due to its weak inhibition to prostaglandin synthesis, and this is very effective to mild to moderate pain and headaches. It has also antipyretic effect, but it does not have anti-inflammatory effect. So it is an opioid, but not an NSAID. It also no antiplatelet effect and no link with Reye syndrome. Side effects and adverse reactions: hepatic necrosis. Overdosing is extremely toxic to liver cells. So you get to expect, or not expect, but rather death may occur 1 to 4 days if left untreated. The same hepatic damage, symptoms: nausea and vomiting, diarrhea, and abdominal pain. Here is the nursing process on the use of non-opioid analgesics, focusing on acetaminophen. Assessment: we are going to obtain a medical history of liver dysfunction. Overdosing is very toxic to liver. It can cause hepatotoxicity, hepatic failure, and death. Next is to ascertain the severity of pain. An opioid NSAIDs, such as ibuprofen or an opioid, may be necessary to relieve pain. Nursing diagnosis: risk for injury, acute pain related to edema from the surgical incision. Planning: we expect that the patient's pain will be relieved or diminished. Interventions: check hepatic enzyme tests for patients who take high doses of drug or simply overdosing. Client teaching: first, keep the drug out of children's reach. Why? Because acetaminophen for children is available in flavored tablets and liquid, and monitored intake can cause high doses, which results in hepatotoxicity, liver failure, and death. Next is to advise not to self-medicate with drug for more than 10 days with acetaminophen, and teach adult caregivers not to medicate children for more than 5 days without the approval of the doctor. Next is to direct parents to call a poison control immediately if the child has taken a large dose or an unknown amount of acetaminophen. Next is to teach patients to check drug dosage in the label of OTC drugs, because it is recommended not to exceed the dosage of acetaminophen and non-opioid analgesics. And again, acetaminophen recommended adult dosage is 4 grams daily. Next is to teach patients to avoid alcohol ingestion while taking the drug, and encourage patients to report the side effects of the intake of acetaminophen, because overdosing can cause, again, liver failure, hepatic damage, and death. So recommended nursing action is to check the serum acetaminophen level if toxicity is suspected. Remember that the therapeutic serum level is at 10 to 20 micrograms per ml, and toxic level is beyond 200 micrograms per ml in 4 hours after ingestion. So in overdosing of acetaminophen, we have antidote acetylcysteine, and the dosage is based on the serum acetaminophen level. Cultural considerations involving the extended family may be important for teaching health strategies and providing support. Evaluate the effectiveness of the drug in relieving pain using a consistent pain scale, again, 0 to 10 pain scale or Raton facial grimace scale. Now, if pain persists, another analgesic may be needed. Another way of evaluating is to determine whether the patient is taking the recommended dosage and observe and report any side effects. So now, aside from non-opioid analgesics, another is opioid analgesic. This is for treatment of moderate to severe pain and obtained with prescription because of the dangers of drug abuse. Properties of opioid analgesics: analgesia, and also suppress respiration and coughing by acting on the respiratory and coughing centers in the middle of the brainstem. So antitussive, this is the property for the coughing suppression. Most opioid has this property, but except for piperidine. And opioid also has antidiarrheal effects. So opioid mostly acts on the CNS by activating the mu receptors, but also with weak activation of the kappa receptors. So, once the mu receptors are activated, we have responses such as analgesia, respiratory depression, euphoria, and sedation are expected. However, for kappa, activated kappa receptors, analgesia and sedation only, there is no respiratory depression and euphoria. So opioid has two isomers, here levoisomers and esteroisomers. So levoisomers has analgesic effect, antitussive response, and it can cause physical dependence. While dextroisomers, no analgesic effect, although there is antitussive response, and it does not cause physical dependence. Side effects and adverse reactions of opioid analgesic: respiratory depression, urinary retention, usually in older adults, and antitussive effects. And common side effects, usually in high doses: nausea and vomiting, especially with ambulatory patients, constipation, moderate decrease in blood pressure, and orthostatic hypotension. So now we have morphine here, one opioid which is extracted from opium. It is a potent opioid analgesic. So the drug is usually administered via oral, IV, rectal, and epidural routes. And this is effective against acute pain from acute myocardial infarction and cancer. It also relieves dyspnea from pulmonary edema and is used to relieve anxiety when used as preoperative medication. Side effects and adverse reactions are the following: respiratory depression, orthostatic hypotension, meiosis or the shrinkage of pupils, urinary retention, constipation from reduced GI motility, cough suppression. So when overdosing of morphine occurs, we have antidote opioid antagonist naloxone. This binds to opioid receptors in the PNS and CNS, thereby inhibiting typical opioid effects. Let's proceed to the nursing process and the use of opioid analgesics, focusing on morphine sulfate. Assessment: obtain medical history for contraindications such as severe respiratory disorders, increased ICP or intracranial pressure, and severe renal diseases. The use of morphine sulfate can also cause seizures. Next is to determine drug history and check for drug allergies. Report if there is any drug-to-drug interaction. Remember, the morphine increases the effects of alcohol, sedatives and hypnotics, antipsychotic drugs, and muscle relaxants, and can also cause respiratory depression. Next is to assess vital signs. Note for the rate and depth of respiration, as well as the pupil size for future comparisons. Remember that opioids commonly decrease respiration and systolic BP and may cause meiosis or shrinkage of pupils. Next is to monitor urinary output, because the use of morphine sulfate can cause urinary retention. Lastly is to assess the type of pain, location, and duration before giving opioids. Nursing diagnosis: acute pain related to surgical incision or surgical tissue injury, an effective breathing pattern related to excess morphine dosage, risk for falls, and constipation related to morphine use. Planning: the same. The pain will be reduced or alleviated. Interventions: administer morphine sulfate before pain reaches its peak to maximize effectiveness of the drug. Monitor vital signs at frequent intervals to detect respiratory changes. So a Respiratory rate less than 10 cycles per minute indicate respiratory distress. Next is to record urine output. Urinary retention is a side effect of morphine sulfate. And remember that the urine output should be at least 600 ml daily. The next is to check bowel signs for decreased peristalsis. So hypoactive bowel signs may indicate constipation as side effect of morphine. Next is to check for pupil changes and reactions. So pinpoint pupils can indicate morphine overdose. Next is to have naloxone available as an antidote to reverse respiratory depression if morphine overdose occurs, and also validate the dose of morphine before administration. In older adults, we are going to check for allergies and irritation because confusion is another side effect of your morphine sulfate. Client teaching: encourage not to use alcohol or CNS depressant with any opioid analgesics because of risk of respiratory depression, dizziness, and potential risks for falls. Next is we're going to suggest non-pharmacologic measures to relieve pain. So during recovery, an opioid analgesic may be prescribed instead of opioid. Next is to alert patients that the continuous use of opioid analgesics may cause addiction. Now, if addiction occurs, we're going to inform them about methadone treatment programs and other resources in the institution. Next is to encourage the client to report dizziness while taking morphine. Dizziness could be due to orthostatic hypotension. Advise them to ambulate with caution or only with assistance. Lastly is to teach patient to report difficulty of breathing, blurred vision, and headaches. Cultural considerations: identify context and values and beliefs about pain and pain management. Respect cultural and religious differences concerning refusal of opioid analgesics. And incorporate traditional practices whenever possible. Evaluation: again, the effectiveness of the drug in relieving pain using a consistent pain scale. Now, if pain persists, another analgesic may be needed. And then another evaluation is to determine the stability of vital signs. And a decrease in vital signs, especially in respiration and BP, should be reported. Another opioid is meperidine. This is one of the first synthetic opioids primarily effective in GI procedures. It is not prescribed for long-term use and is frequently limited to 150 milligrams per dose for periods no longer than 48 to 72 hours. It can be administered via oral, IM, or IV routes. It has no antitussive property common to opium preparations, and it is used or preferred than morphine during pregnancy because it does not diminish uterine contractions and there is less neonatal respiratory depression. Side effects and adverse reaction: less constipation, urinary retention than morphine. Expect decrease in BP, especially in older clients, so there is frequent monitoring of VS. And another is neurotoxicity, usually in large doses and in older adults and in clients with advanced cancer. Signs and symptoms of neurotoxicity includes nervousness, tremors, agitation, irritability, and seizures. Interactions: it should not be taken with alcohol or sedative hypnotics because it may cause an additive CNS depression. Opioid meperidine, duration of action is shorter than morphine and it is metabolized in the liver. It is excreted in the urine in metabolite form, being normepiridine. Contraindications: chronic pain, severe liver dysfunction, sickle cell disease, history of seizures, severe coronary artery disease, cardiac dysrhythmias, and it is cautioned to patients having renal insufficiency and hepatic damage. So, gina-decrease ang dosage if mag-treat sa kanang patients. Another is opioid hydromorphone. This is a semi-synthetic opioid similar to morphine. It is administered for relief of moderate to severe pain via oral, rectal, subcutaneous, IM, and IV routes. And the analgesic effect is 6 times more potent than morphine, with fewer hypnotic effects and less GI distress. The onset is faster than morphine, while duration is shorter than morphine. It is readily absorbed in the body and excreted in the urine. Recommended nursing action with the use of hydromorphone is to closely monitor respirations and ensure that adequate hydration is provided to the client. Side effects and adverse reaction. There are actually a lot of side effects, but the following are of importance. First is orthostatic hypotension, drowsiness, dizziness, weakness, confusion, constipation, urinary retention. Now, side effects and adverse reactions seen with prolonged use. We have a papillary constriction of sign of toxicity and drug tolerance. This is from increased metabolism. This causes an increased need for higher doses of an opioid. Another is psychological and physical dependency with withdrawal syndrome. And the symptoms of withdrawal syndrome include irritability, diaphoresis or extreme or excessive sweating, restlessness, muscle twitching, tachycardia, increased blood pressure. These symptoms occurs within 48 hours after the last use of opioid after cessation. So now here is the contraindications of opioid hydromorphone or within the use of opioid analgesics. Here is head injuries because it decreases respiration. So decreased respiration promotes carbon dioxide retention, resulting in increased intracranial pressure. Another is respiratory disorder. It intensifies respiratory distress. Now, patients having asthma, opioids decrease respiratory drive and simultaneously it increases airway resistance. It is also contraindicated in patients in shock or with decreased blood pressure because it may cause hypotension. However, if an opioid is necessary, the dosage of opioid is adjusted. The use of hydromorphone and analgesics, opioid analgesics, is cautioned to older clients or debilitated patients, and the dosage is decreased for them. Next, we have our combination drugs. So combination drugs is used to reduce side effects because when you use combination drugs, you're only requiring small amounts or smaller doses for each drug, thereby reducing the side effects of the drugs. They're also used to decrease drug dependence. Now, it helps reduce drug dependence from the long-term and constant use of an opioid agent. So the combination drugs is used to treat moderate to severe pain. It usually comprises an NSAID and an opioid analgesic, such as your ibuprofen and hydrocodone combination drug. To treat mild to moderate pain, acetaminophen and codeine combination drug is an example. So the continuation of opioid analgesic discussion is with student nurse Parcon. Thank you.
Hello, I am Johann and I'll be talking about patient-controlled analgesia pumps. So these are a method of pain control wherein the patient has the power to change or to control the amount of dosage depending on the pain level or the amount of pain that they are experiencing. So this pump is set to release small amounts of pain medication, and the patient has the power to change or add additional amounts of medication depending on what they want. So are patient-controlled analgesia pumps safe? Of course, so they are safe because they have this mechanism or a safety feature wherein wherein there is a limit to what extent the patient can self-administer the amount of pain medication. So that's how patient-controlled analgesia pumps are safe to use. So moving on here is we're going to be discussing the dosage. We have the side effects and also the adverse effects or toxic reactions. So for dosage, we have IV for adults and elderly is usual concentration is at 1 milligrams per ml, and the demanded dose is at 1 milligrams with a range of 0.5 to 2.5 milligrams, and lockout intervals is between 5 to 10 minutes. For side effects, the patient may be experiencing sedation, decreased blood pressure, that includes orthostatic hypotension, diaphoresis, drowsiness, nausea, vomiting, allergic reaction, dyspnea, confusion, palpitations, tremors, urinary retention, vision changes, abdominal cramps, headaches, decreased appetite, pain or burning at injection site. And for adverse effects or toxic reactions, is overdose might result in respiratory depression. Also, skeletal muscle flaccidity, cold clammy skin, cyanosis, extreme drowsiness progressing to seizures. We have stupor, we have coma, and tolerance also to analgesic effect, and the medication won't have much effect for the patient. Physical dependence or addiction may happen, and prolonged duration of action, cumulative effect may occur in those with hepatic or renal impairment. For the nursing considerations, we will start first with the baseline assessment. So the patient should be in a recumbent position before a drug is given by parenteral route. We have to assess the onset, the type, the location, and duration of pain, and obtain the vital signs before giving any medications. If If respirations are 12 per minute or less, or 20 per minute or less in children, we have to withhold the medication and we have to contact the physician. And we also have to take note that effective medication is reduced if full pain recurs before next dose. For the intervention and also evaluation is we have to monitor the vital signs of the patient 5 to 10 minutes after IV administration, 15 to 30 minutes after subcutaneous and intermuscular administration. So we have to be alert for any decreased respirations or blood pressure. We also have to check for adequate voiding and monitor daily pattern of bowel activity, stool consistency, and avoid constipation. And then we have to also initiate deep breathing, coughing exercises, particularly in those with pulmonary impairment, and assess for clinical improvement, record onset of pain relief, and consult the physician if pain relief is not adequate. For last under nursing considerations are patient or family teaching. So we have to tell the patient that discomfort may occur with injection. We have to tell the patient to change position slowly, and that is to avoid orthostatic hypotension, and then have to tell the patient to avoid tasks that require alertness, motor skills until the response to drug is already established. We also have to tell the patient to avoid alcohol, CNS depressants. Tolerance may depend, or dependence may occur with prolonged use of high doses, and then we also have to report ineffective pain control, constipation, and urinary retention. So now I'll be talking about transdermal opioid analgesics, specifically fentanyl transdermal or Duragesic. Okay, the indication of this drug is to moderate to severe chronic pain in opioid-tolerant patients requiring use of daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. For action, it binds to opiate receptors in the central nervous system, altering the response to and perception of pain. For therapeutic effects, it is a decrease in severity of chronic pain. And for pharmacokinetics, the administration is well absorbed through the skin surface, 92% of which is going to well absorb 92% of the dose. And then for the distribution, it crosses the placenta and also enters the breast milk. For the metabolism, it is mostly metabolized by the liver and excretion by the kidneys. For pharmacokinetics, the onset is on 6 hours. The peak is during 12 to 24 hours, and the duration is 72 hours. For dosage is for adults, elderly, and children, and also 12 years and older. Initially, they have 12 to 25 micrograms per hour, and it also may increase after 3 days. For contraindications, it is contraindicated to patients who have hypersensitivity to fentanyl, significant respiratory depression, acute or severe bronchial asthma, paralytic ileus, GI obstruction, significant respiratory depression, acute or severe bronchial asthma, paralytic ileus, and for patients who are not opioid tolerant. For its side effects we have headache, pruritus, nausea, vomiting, diaphoresis, dyspnea, confusion. We have dizziness, drowsiness, diarrhea, constipation, decreased appetite, chest pain, arrhythmia, pruritus, syncope, agitation, and skin irritations. And for adverse effects or toxic reactions, we have for the central nervous system, we have confusion, sedation, weakness, dizziness, restlessness. For the respiratory system, we have apnea, bronchoconstriction, laryngospasm, respiratory depression. For cardiovascular, we have bradycardia, we have hypotension. We have for the GI, we have anorexia, constipation, dry mouth, nausea, and also vomiting. For the integumentary, there could be sweating, erythema. And for the endocrine, we have adrenal insufficiency. For the musculoskeletal, we have skeletal and thoracic muscle rigidity. And then for miscellaneous, we have physical dependence and physiological dependence. For the nursing considerations, we have to start with the assessment. So for the assessment, we have to first assess the type, location, and intensity of pain before and after 24 or after application, and periodically during the therapy. You also have to monitor the pain frequently during initiation of therapy and dose changes to assess need for supplementary analgesics for breakthrough pain. And then you have to also assess the blood pressure, the pulse, and respirations before and periodically during administration, because if respiratory rate is less than 10 per minute, we have to assess the level of sedation. If physical stimulation also may be sufficient to prevent significant hypoventilation, those may need to be decreased by 25 to 50%. Then we have to also assess for bowel function routinely. We have to prevent constipation with the increased intake of fluids and bulk, and laxatives to minimize constipating effects. Then we have to also assess risk for opioid addiction or abuse or misuse prior to administration, because misuse or addiction may result to overdose, and which can be harmful for a patient. For implementation, we have to apply to hairless area of intact skin of upper torso. You also have to use a flat and non-irritated site. You have to press firmly, firmly press evenly and hold for 30 seconds, ensuring that adhesion is in full contact with skin and that edges are completely sealed. So lastly, for family teaching, is we have to of course teach the patient the proper transdermal administration. Also have to tell the patient to avoid alcohols, because you should not take any medications without consulting the physician. And then you also have to avoid tasks that require alertness, motor skills, until the response to the drug is already established. And you also have to avoid saunas, because it increases the drug release time. Moving on is then I will be talking about analgesic titration. So opioids should be titrated, and that is for us to be able to achieve the best result by balancing the pain relief and the side effect that is felt by the patient. And then there is also research that stated that the younger the person is, the larger the dose might be needed. And then opioids need to be titrated by percentages rather than fixed amounts. So of course you have to first start initiating opioids safely. So first is you have to assess first the risks to patient safety by conducting a physical examination, mental health screening, prescription drug monitoring program, and also urine drug tests. And then you have to set goals for improvements in pain and function with the patient, and check that non-opioid therapies are tried and optimized. You also have to discuss risks and benefits with the patient and establish criteria for stopping or discontinuing opioid therapy. Then we have to initiate the treatment with immediate release opioids, and that is for us to be able to reevaluate the benefits and harms with patients within 1 to 4 weeks of starting opioid therapy of those escalation. Now I'll be talking about morphine milligram equivalents. So morphine milligram equivalents is an opioid dosage equivalency to morphine. So the morphine milligram equivalents or per day metric is often used as a gauge of the overdose potential of the amount of opioid that is being given at a particular time. Calculating the total daily dosage of opioids helps identify patients who may benefit from closer monitoring, reduction of or tapering of opioids, prescribing of naloxone or other medications to reduce the risk of overdose. And for now is we're going to be calculating the MME. So we have to use the following method for calculating the MME per day. So you have to determine first the total daily amount of each opioid the patient takes, and then convert all the opioid to MMEs by multiplying the daily dosage for each opioid by its conversion factor, which is shown in the picture here. And then we have to add all opioid MMEs together. So now I'll be talking about opioid use in special populations. So here we have 4 populations that you are basing on. We have the justice-involved population. So in justice-involved populations, we have 10 million people that pass through the justice system per year, and 2 million people are confined in U.S. jails or prisons daily. So this is based in the U.S. And I think that amount of population contributes to the amount of abuses or opioid uses. And then among those who encounter also the justice system is the rates of opioid use are significantly higher than in general population. From 2007 to 2009, more than a quarter of those who were detained in prisons or jails reported a history of opioid use. And as the intensity of opioid use increases, the likelihood of justice involvement also increases. Jails and prisons represent one of the largest providers of treatment for substance disorders. Next one is for the veteran population. So for a veteran population, chronic pain is more frequent or more common for them and more severe in veterans than compared to non-veterans. Among veterans, which also causes them to intake opioids. So among veterans, pain is often complicated by high rates of mental illness that includes SUDs, which increases the risk of misusing opioids to treat pain, depression, and also serious mental illness. Next one is for the adolescents and young adults. So they are at critical risk stage for substance use and require special attention when viewed through the lens of opioid epidemic. Due to the developmental tasks of adolescents and young adult periods, it increases vulnerability to use opioids and unique challenges that this phase of development presents to the prevention and treatment of opioids use disorder. So also around sa mga adolescents and young adults, their brain development is not that complete until early adulthood and around 25 years old. In addition to physical vulnerability, adolescents and young adults have in addition to physical vulnerability, executive control, judgment, empathy, and insight skills are still being also developed in adolescents. And also, due to premature developmental skills, they make decisions that are based on their emotions. And that's why adolescents and young adults are at critical risk or at most contributes to the population of opioid use. Now we'll be talking about adjuvant therapy. So what is adjuvant therapy? It is a therapy that is often used after primary treatments, such as surgery, to lessen the chance of your cancer coming back. And then also, it also could possibly mean that it is a therapy that is in addition to a surgery that is going to be performed. So which treatments are used as adjuvant therapy? So types of cancer treatments that are used as adjuvant therapies include the chemotherapy. So chemotherapy uses drugs to kill cancer cells throughout the body. Next one is we have the hormone therapy. For cancer sensitive hormones, certain treatments can stop hormone production or block the effects of those hormones. And then we have the radiation therapy. For radiation therapy, it uses high-powered radiation or energy beams such as X-rays or protons to kill cancer cells, and then it can also be given internally or also externally. So we also have the immunotherapy. So immunotherapy works with your body's immune system to fight off any remaining cancer cells by stimulating your body's own defenses or supplementing them. And lastly, we have the target therapy. Target therapy is designed to alter specific abnormalities present within cancer cells. For example, a targeted therapy is available to block the action of a protein called human epidermal growth factor receptor 2 in women with breast cancer. So now I'll be talking about treatment, opioid addiction treatment. So first, I will be talking about what makes opioid addiction, or what causes opioid addiction. So what causes opioid addiction is when you take opioid drugs, your brain creates artificial endorphins, and this endorphins not only relieves pain, it also makes you feel good, and that's why others are getting addicted. And also, when you're creating endorphins, when your brain starts to rely on these artificial endorphins, and when the brain does this, it stops on creating its own endorphins, and once it stops creating its own endorphins, okay, you will keep on relying on endorphins. So that's what causes the addiction of opioid. So for starting is we have to our main goal for this treatment is to help the patient stop using the drug. When you stop taking the drug, there is backfires, or what you call withdrawal, wherein the body will react, and then you have numerous symptoms such as nausea, vomiting, abdominal pain, and anxiety. So those are what could happen when your body reacts when you stop using opioids. So your doctor can prescribe certain medicines to help relieve your withdrawal symptoms. They will also help you control your cravings. So the drugs that could help you are methadone and buprenorphine. So this will help you reduce withdrawal symptoms by targeting the same centers in the brain that opioids target. But also we have what we call naltrexone, which helps you to prevent from relapsing. So relapsing means to start taking opioids again. So it prevents you from relapsing. This medicine is different from methadone and buprenorphine because it does not help you with your craving or withdrawal. Instead, it prevents you from feeling the high you would normally feel when you take opioids. And then behavioral treatments can also help you learn how to manage depression. So behavior treatments include individual counseling, group or family counseling, and cognitive therapy. So ask your doctor for recommendation. So which treatments are used as adjuvant therapy? So types of cancer treatments that are used as adjuvant therapies include the chemotherapy. So chemotherapy uses drugs to kill cancer cells throughout the body. Next one is we have the hormone therapy. For cancer sensitive hormones, certain treatments can stop hormone production or block the effects of those hormones. And then we have the radiation therapy. For radiation therapy, it uses high-powered radiation or energy beams such as X-rays or protons to kill cancer cells, and then it can also be given internally or also externally. So we also have the immunotherapy. So immunotherapy works with your body's immune system to fight off any remaining cancer cells by stimulating your body's own defenses or supplementing them. And lastly, we have the target therapy. Target therapy is designed to alter specific abnormalities present within cancer cells. For example, a targeted therapy is available to block the action of a protein called human epidermal growth factor receptor 2 in women with breast cancer.